This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the journal Fluids and Barriers of the CNS, published in 2026. The title is Ventricular Volumetry in Relation to Clinical Response and Overdrainage After Shunt Surgery in Idiopathic Normal Pressure Hydrocephalus, a 3-year prospective study.
This is a topic that hits home for anyone who spends time in a dedicated hydrocephalus clinic. We've all seen those patients with idiopathic normal pressure hydrocephalus, NPH, who do beautifully after a shunt. But we also live in constant fear of the dreaded subdural hematoma from overdrainage. This study really tries to put some numbers behind those clinical observations.
Exactly. And what's impressive here is the time frame. Most studies on INPH look at 6 months or maybe a year. This was a 3-year prospective study. They followed a cohort of patients to see how their ventricular volume changed over time using automated volumetry, and how those changes correlated with their actual clinical improvement, or lack thereof.
Right, because for decades we've relied on the Evans index, a simple 2D diameter ratio. But as we know, the brain and the ventricles are 3D structures. Alara, walk us through the primary objectives of the researchers here.
Of course. The researchers wanted to quantify the longitudinal changes in ventricular volume after shunt surgery. Specifically, they were looking for 2 things. First, if the reduction in volume correlates with clinical improvement in gait, balance, and cognition. And second, if there's a threshold of volume reduction that predicts overdrainage complications, like subdural hygromas or hematomas.
It's a classic neurosurgical dilemma. You want the ventricles to come down to show the shunt is working, but if they come down too much, you're looking at a revision or a setting change on the valve. What did they find regarding the timing of these volume changes?
This was one of the most interesting parts. They found that the most significant reduction in ventricular volume happens early, within the first 3 to 6 months post-op. After that, the volume tends to stabilize. By the 3-year mark, the ventricles were significantly smaller than baseline, but the delta, the change, was largely achieved in that first year.
That aligns with what we see in practice. If you don't see a change in the imaging by 6 months, you start wondering if your pressure setting is too high or if the shunt is even patent. But let's get to the clinical side. Did the patients who had the biggest shrinkage in their ventricles actually do the best clinically?
Surprisingly, the correlation wasn't as linear as you might think. While almost all patients who improved clinically showed some reduction in ventricular volume, the magnitude of that reduction didn't strictly predict the degree of clinical recovery. In other words, a patient whose ventricles shrank by 20% might have the same gait improvement as someone whose ventricles only shrank by 5%.
That's a crucial point for our residents listening. Don't treat the scan, treat the patient. I've seen residents get worried because the ventricles still look large on the post-op CT, even though the patient is walking better than they have in years. According to this study, that's actually quite common.
Precisely. The paper notes that the brain's compliance in these older INPH patients is often reduced. The ventricles may remain stretched even when the pressure is normalized. However, they did find that a lack of any volume reduction was often associated with poor clinical outcome, which suggests that some degree of decompression is necessary for the white matter tracts to recover.
Now, let's dive deeper into the complication side, overdrainage. This is the high-stakes part of the paper. What did the volumetry tell us about those patients who developed subdural collections?
This was a major focus. The study found that patients who developed symptomatic overdrainage had a significantly higher rate of volume reduction in the immediate postoperative period. If the ventricular volume dropped by more than a certain percentage, the paper points towards a rapid 15 to 20% decrease. The risk for subdural hygroma skyrocketed.
So it's not just about the final volume, but the velocity of the change.
Exactly. It's the rate of collapse. They suggest that the cortical mantle pulling away from the dura too quickly is what shears those bridging veins or creates the vacuum effect for hygromas. Interestingly, they observed that in some of these cases, the Evans index didn't change much, but the total 3D volume dropped significantly. It shows the limitation of 2D measurements again.
Which really argues for the adoption of automated volumetry in our standard follow-up. Most modern PAC systems can do this now. If you see a 20% volume drop in month 1, even if the patient feels great, you might want to proactively increase the valve resistance.
And the study backs that up. They noted that by using programmable valves, they could often arrest that volume loss and see a stabilization of the subdural collections without needing to evacuate them surgically. The 3-year data showed that most of these overdrainage patients eventually stabilized if the valve was managed correctly.
Let's talk about the long term. At the 3-year mark, did the clinical benefits hold up? INPH is a progressive disease, after all.
The study showed that the majority of responders maintained their clinical improvement at 3 years. However, there was a subset of patients who showed late failure. Their ventricles remained small, meaning the shunt was still working, but their gait and cognition began to decline again.
That sounds like the dual pathology problem, concomitant Alzheimer's or vascular dementia.
Exactly. The researchers noted that in these cases, the volumetry was actually a helpful diagnostic tool. Since the ventricular volume remained stable at its lower post-op level, the clinical decline couldn't be blamed on shunt malfunction. It pointed the clinicians toward neurodegenerative causes instead.
That's a pearl right there. If the patient gets worse, but the ventricles stay small, don't just keep turning the valve down. You're just going to cause a subdural. Look for other pathologies.
One other key detail from the paper, they looked at the temporal horns. They found that the reduction in the size of the temporal horns was actually a better predictor of clinical response in the cognitive domain than the reduction of the lateral ventricles as a whole.
That makes sense anatomically, given the proximity to the hippocampi. If we can relieve the pressure on those medial temporal structures, we might see better memory and executive function scores. Did they mention any specific software for the volumetry?
They used a standardized automated segmentation tool. The key takeaway was that it was reproducible. They're advocating for this to become the new gold standard over the Evans Index, which they described as clinically useful but physiologically limited.
So if we're summarizing the practice-changing aspects of this 3-year study for our listeners, Alara, what are the top 3?
First, ventricular volume reduction is a front-loaded process. Most of what you're going to get happens in the first year. Second, while you need some reduction for success, more reduction doesn't mean more improvement. It just means more risk of overdrainage. And third, use volumetry to differentiate between shunt failure and disease progression in your long-term follow-ups.
Excellent. It's also a reminder that INPH management is a marathon, not a sprint. A 3-year perspective is so much more valuable than a snapshot at 6 weeks.
Definitely. The paper concludes by suggesting that tailored shunting, adjusting the valve based on volumetric trends rather than just symptoms, could be the future of preventing complications.
Well, that's all the time we have for today's episode. For the residents listening, I highly recommend pulling the full text of this one from Fluids and Barriers of the CNS. The graphs on volume velocity and subdural risk are particularly useful for your next board review or grand rounds.
Thanks for joining us. We'll see you next time on the Neurosurgery Hub podcast.
Goodbye.